Welcome to the Heart of Healthcare with Dr. G. This is a podcast that is unafraid to address current issues regarding top healthcare needs and concerns. All righty, well, I'm going to go ahead and get started first, as we always do, with our prayer for the day, mostly because we're letting the Almighty guide us in this podcast here. Our prayer is from 2 Kings 25, verse 5. This is what the Lord, the God of your father David, says. I have heard your prayer and seen your tears. I will heal you. Amen. Yes. With that being said, I'd like to introduce myself. I'm Toni Kiskin, your host, and this is Dr. G, who the show's all around, and we're excited. Welcome, Dr. G.
It's not around me. We're partners.
Yes.
So I'm Kayshana Guidry, MD, Palliative Medical Director here at Destiny, our sponsor, wife, mother, friend.
All of the above?
All of the above, and here to serve you guys with the knowledge I have to empower you to take control of your health or your loved one's health. That's why we are all here, so we can provide education to the community.
Absolutely. And today we're going to talk about skilled home health care versus custodial care. It is absolutely the most confusing issue for most people. And we really want to dive into it because we want you folks out there to really be able to have a good handle on what the differences are. Mm-hmm. Not very many people really recognize that they're even different. Home health is actually a federally mandated program under Medicare. It was put into effect in 1965 by Lyndon B. Johnson. And so it's been around for a very long time. Medicare pays for this, and we're going to go into that a little bit more. Mm-hmm. Home health actually is something that most people think is the same as home care.
Right.
Yet home care is not a federally sponsored program. It's actually paid for privately. And some people that are fortunate enough can have paid for this through long-term care insurance.
Right.
But it's very expensive. So most people, at least the folks that I've met, really very few people they got to figure it out.
Yeah.
And that's kind of been something that a lot of people talk to me about. And it's really at the heart of a lot of family situations, especially right now after the pandemic. With COVID, a lot of families were able to come home and spend time with their loved ones. And they're really able to take care of them, especially those that got COVID. And they were able to be there for them, work with the oxygen, all the different things that were going on. But now that we're getting into a place where we're opening up, folks are getting their vaccines, they've got to go back to work. Mm-hmm. Mm-hmm. And that just really is putting kind of a big damper on the whole thing.
Yeah. I, needed to learn more about this situation because I often hear, nurses, or even today when I went to a skilled nursing facility, oh, some people are here for this and other people are custodial. That word I never, what does that actually mean?
Yeah.
But the way that I see this topic is through my family, because last year my husband's father fell ill, and he was, luckily able to stay home and provide some of the primary caregiving because he had that flexibility with his work. And so we ran into some of those issues, initially just trying to know what's going on. But when I see patients, everyone's often wondering, okay, what am I going to do? How do we get this? I need someone to help turn them. Just yesterday, I had a patient who with MS, and they need 24-hour care, mm-hmm. and they're having some, the brother said, some caregiver upheaval. When you don't have reliable care, it can be really challenging. So it's important that the community knows about what options are available. So I'm glad we're doing this.
Absolutely. And what you just shared about your own family and then the patients that you've gone out and see is what everybody is faced with, and they just don't know the difference. So what we're going to do first is we're going to actually talk a little bit about the Medicare, which is actually the skilled home health care. So when you hear skilled care, it means that an individual has needs that are recognized by Medicare as diagnosis codes that they're able to say, you know what, they need some extra help. And it might be a disease process, something like congestive heart failure. You know, we talked about COVID, it could be COVID. Those are things that they'll say, you know what, home health needs to come in and take care of. And usually what's involved with that would be nursing, physical therapy, occupational therapy, speech, home health aid, social work. And those are, different disciplines that are able to come in and really work with the family. And it's all covered under the Medicare benefit, which is really nice, as long as they meet certain criteria. Now that's the interesting thing. So we talked about the diagnoses. So let's say they've got, well, let's go with congestive heart failure. They've got congestive heart failure, and home health has been ordered for them, but they want to be able to go to the casino. They're feeling better. The Lasix is working. They're not as swollen. They don't have that that edema in their ankles, and they feel better with their shoes on, and they want to be able to go to the casino. And we're calling them to go ahead and set up a visit, and we find out they're going to the casino. Well, guess what, Dr. G? We can't go because they have to be homebound. So under skilled care, one of the things that falls under that is they've got to be homebound. And what does homebound mean? Homebound means that they really are only going to go out for doctor's appointments, church, and maybe some groceries, that kind of a thing. But they're not going to go to the casino. They're not going to a theme park. They're not going to go, those kinds of things. Right. And so, in those instances, families sometimes can get really upset because they ask their doctor or maybe a case manager for this care, but they're not able to get it because they just can't go to the casino. Wow. That part of it is really interesting. Wow. Now, how else is Medicare involved? Well, Medicare will then say, you need to really look at what's going on and document well. We like to keep these folks out of the hospital, and so we really need to work closely with them. So we're going to try to get in there and do these visits, usually in maybe 2 to 3 in the first week, depending on the doctor's orders, those you know very well about, and then the next week maybe the same kind of a thing. And we want to try to get these in. We call it front loading in the beginning, so that we are able to feel confident that they're not going to go back into the hospital. So it's covered by Medicare. We talked about that. It's covered by senior health plans. So that might be like Aetna, Blue Cross, Blue Shield, Humana. They might give their Medicare over to a managed care company, and then they manage it for them, which is the reason they call it managed care. The other way that it might be covered is under the VA, Veterans Benefits. And those are great benefits. They're able to access that, and they're able to get the skilled care as well. They also may be able to get it if it's a younger person. So let's talk about somebody under 65, a commercial health plan, which is still the ones that we talked about, Blue Cross, Blue Shield, those kind. What are these visits like? Do we go in for 1, 2, 3, 4, 5, 6, 7, 8 hours? Sometimes I get orders and they want us to stay in for 8 hours at a time. No, they're intermittent. So intermittent means that we're in, we're out. We go in, we take a look at what's going on, what the diagnoses is, we take the vital signs. And in a lot of families, this is something I really want to discuss, because you're going to know very well why this is so important. A lot of families, we come in and we've got someone, let's keep with the congestive heart failure. And we're going to go ahead and we're going to take their blood pressure, we're going to take all of their vital signs, their pulse, their temperature. We're probably going to take a pulse ox or oxygenation to see what their levels are for their oxygen. And then we're going to really do a lot of skilled observation. Well, a lot of families get upset with that and think all they're doing is coming in here. I don't need them. They're just taking my vital signs. I don't need them. Let's talk about what those skilled observations might be in a congestive heart failure patient.
Well, I think we'd be using that pulse ox to
Yes.
see if they desaturate, off of oxygen, if they're on oxygen. Physical therapy, obviously,
Yes.
if the edema is making them non-ambulatory.
And the edema, a lot of people don't recognize that under skilled care, we're using the eagle eyes to look over their body for edema and how much is it pitting, and touch on that a little bit.
Right. So how much is it pitting? If, the doctor may need to increase the Lasix or diurese them a little bit extra for a couple days. Other things I can think of is managing the oxygen.
Absolutely. And a lot of times it's looking at their medications.
Reconciling those meds.
Yes, reconciliation is huge. You're exactly right, because we might note that they've got some Lasix that might be a year old and they were supposed to get a new one filled, but they didn't, because we understand that it's quite expensive, but we need to have the most current medication so that it works the best.
Yep.
So that's something that families oftentimes don't recognize when we're going in there. We might look for shortness of breath to see, even though we're doing their pulse ox, checking that oxygenation, we might have them get up, walk a little bit around, and they don't understand exactly why we're asking them that. And that's just really to see, do they get short of breath, and do they desat after they come back, right?
Yeah, that's all important.
Yeah, and so the other thing that we might do is then maybe their blood pressure was a little bit elevated. We may have to end up taking it again and getting a hold of the doctor, letting the doctor know, that do we really, the last couple times that I've come, it's just going up. Do we need to change these medications?
Or too low, because
Right.
they're a fall risk.
Exactly. And too low is important. And that's something I'd like for you to maybe touch on, because there's those parameters for them to be able to not take that, and share that with our folks.
Yeah, so every patient would be different in the situation we're talking about with CHF. Depends on their ejection fraction, how much their heart is pumping, how strong, what percentage of the blood is leaving the heart. For those folks that have a low ejection fraction, they might need a higher blood pressure to get that blood to the body. Other folks, if they have a higher one, they may be able to sustain those lower numbers. So it's always valuable when the nurses are going there, getting this data, and then reporting it back to the doctor. I'm seeing it on that side. In residency, I ordered home health for so many people.
Right.
And so seeing it on the other side is very, very interesting to know how valuable the information is. And some of the patients that I have who are homebound, graduated from hospice, and they're at home, and they need close oversight that the home health nurses provide. So it's really important and valuable for me.
Absolutely. And then if they've got AFib, we know that blood pressure and that pulse is going to be very important. And if they're taking, their medications, and then we may have to do labs, draw some labs for them, those kinds of things. So these are all just kind of a short little list of things that would be needed for intermittent skilled care. And we talked about how it's paid. What I want to talk about right now, though, is I want to talk about then the difference. What is home care? And home care is the custodial. That's where a lot of folks will they'll go to their doctor, or they'll be getting out of the hospital, and they say, I need to have home care because I've got to go back to work, and somebody's got to babysit my mom or my husband or my loved one, whoever it may be, so that I can get back to work. And lo and behold, we get an order to go out and to do home health, because remember, we're skilled. So some agencies, they're usually very separate. They have to be very separate, some custodial, some skilled. We'll get that order and we call up to set up the visit. And they're like, so I need you to be here from about 7 till about 3:30 or so, because by the time I get home from work, and it's like, okay, wait. We're skilled care, we're intermittent. Well, that's not what I told my doctor I wanted, and my doctor said that they were going to order this, and I know that my insurance must cover it because my doctor wouldn't order it.
Oh.
Yeah, it's not the case.
That's tough.
It's not the case. So we go through, and that's what I'm going to go through the scenario right now. Unfortunately, if individuals do have to go back to work, similar to what you discussed in your own family, and they do have to go back to work, how is that paid for? Well, first of all, if they do have long-term care insurance, which I did allude to, there's many hours, there's money invested in that, and they have hours for exactly 8 or 10 or 12 hours, whatever it is that they need. But if they don't, which most people don't, now they're going to have to pay privately. They'll call a home care company up that is considered a private duty company. And they'll call them up and they'll get an estimate. For a caregiver, which is usually what they need, that's the kind of person that kind of babysits. For a caregiver, it can range, the price range, depending on what part of the country you're in, can be, from any range. And do they monitor, do background checks on them? Do they insure them? Are they, insured? And there's a lot of homework to be done there. And it's not easy for a family, that's for sure. And I can feel why they would be frustrated about not being able to just call us and have us do it. Or why doesn't Medicare cover this? Why wouldn't I be able to have this? But the truth of the matter is, and I always try to go back to this, it's kind of like when we have children. I've got 2 children myself. You've got 3.
Well, 3 adults.
Yeah, well, yeah, but they're still our babies, right? So those kids, when they were younger and we had to go to work and they weren't feeling well, did we have anybody that could babysit them for us?
Well, I had chosen to be a stay-home mom, so it's kind of like the situation with my husband. So I had made that choice to be home with him, so I didn't have to worry about that. But I can see how, my friends who had careers in medicine or whatever they were doing,
right?
They had to go back to work, so they had to figure something out.
And that's exactly right. So, and if you think about that, and you have a child and they're sick, and you do have to go to work, the only thing that you can do, because no one's going to pay for it. There's nothing out there. There's not a resource. There's not a Medicare. There's not an insurance that's going to pay for it. You've got to call on family. Because they're not going to take them to school, especially if they got something like chicken pox or, something that's very contagious. They're not going to take them in school. So you really got to call on somebody that's going to be able to come in. And that's the same difference. What we're dealing with right now is a situation with families that don't recognize we're living longer, a lot longer. And families just don't recognize that there's just not a resource out there that is able to come in and pay for it, like a Medicare or a commercial insurance. Now, some families might qualify under the Medicaid program in California, which is where we're at. It's called Medi-Cal. And if you do meet that criteria, you're able to get what's called in-home support services. They'll give so many hours in a month, and they'll be able to come in. But quite honestly, it's still not going to be enough for someone to be able to go to work, come home, and have full confidence that someone's been there the whole time. It just doesn't work that way. So for the most part, I usually try to recommend that if they can't pay for it privately, sometimes they can use, because there's just not the funds, they can use a life insurance policy. Life insurance policies can be cashed in. So if they've got a life insurance policy, they can give a call, see if they won't get the full amount, but they can oftentimes, that will give cash. Another thing that sometimes we'll talk about is a reverse mortgage, if they own a home, because a lot of times that's what makes them not qualify for other things. So this way they can get some cash out. That way that will allow them to be able to get the coverage that they need. But if all of that is unreasonable for families, and a lot of times it is, and I hear about that all the time, the only thing that you can really do is reach out to a church family. Church families oftentimes will come in, they'll take turns, they'll really help you. Neighbors. The other thing is extended family. A lot of families don't think about those that might live out of state, and they might be maybe taking a gap year in college, or maybe they're just finishing up high school, or with COVID, sometimes the kids still are not back to school and they can do it online. Those are things, but whatever it is that they do, and we're not here to have all of the answers, right? We're here just to give some ideas and some resources. The bottom line, though, is that under this situation, there's not anybody at all that's going to be available to be paid for by insurance. So to reiterate, we've got the 2 programs, but they're very different.
Right.
One is for skilled care, and it's intermittent. That one was passed in 1965. It's covered by Medicare or managed care or other health plans. The VA benefits as well. The other one is home care. That is pretty much custodial. It is custodial care, and it's only caregivers, so that people can go to work. They can get someone to take them to the doctor. They can get somebody that's able to drive them. Maybe they want to go on an outing, because who wants to stay in the house all the time now that we're getting open more? A lot of people want to get out. It's coming to the best time of the year, spring, and they want to get out. So those are the services that kind of can really cover those. And that works out really well. What are your thoughts, being a doctor, in ordering these kinds of things? I'm hoping that it helps a little bit to clarify that.
Yeah, I think with all of your experience, you're shedding light on the challenges that families face. Again, when we're in hospitals, discharging folks, offices, it's important for us to be aware of what's the hot topic, social determinants of health. So all the things that would affect our patients. So do they have a support system? Do they live alone? Are there some challenges that they have that could interfere with them being healthy at home,
Right.
Staying out of the hospital? So this I think sheds good light on it and shows folks, what the options are for them.
Yeah. Well, and I think, the number one thing that you and I always want to do at these podcasts is really kind of demystify and help families so that they're not going to get upset or angry. It happens a lot, as I mentioned in the very beginning, that without understanding what's available out there, it just makes it really hard. Oftentimes you might want to reach out to your Office on Aging as well.
Mm-hmm.
In some states and counties, they're able to deliver Meals on Wheels. They're able to offer all kinds of different kinds of resources. Families might not have ever considered, but there's daycare sometimes as well, for that seniors can go to also. And you can kind of take a look at those kinds of avenues. But at the end of the day, the thing that cannot be done with home health, that is the skilled care, is that it cannot cross over into custodial care. Those two can never meet. And if they do, then there's just trouble that's going to happen there, because that was never the intention of the regulation or the benefit. And remember, these are benefits that the federal government put into place under the home health benefit, just like we talked about hospice last time. It's a benefit that they put into place, and I mentioned 1965, and it's mostly because they recognized at that time that families did need to be able to have care. They don't want to go to a skilled nursing facility. It's time for them to be discharged out of the hospital, and what is it that they're going to do? So it is a lovely benefit available, but we really want to help you to understand it a little bit more. I want to just see if you've got any other thoughts about that.
No, I mean, this is great. I think we should just remind them of our email. They can send in questions and we can dig deeper, because we're going to be on this journey of unpacking all these topics at the heart of healthcare.
Absolutely, and that is a very great segue. So thank you, Dr. G, for that. So we are at the heart of healthcare with Dr. G, and this is our podcast, and we love that whoever's following us, please tell as many people as you possibly can. Our goal is to give you information like this, but it's also to be able to answer questions. So you are able to go ahead and email us at hello@destinyhospicecare.com. And if you email us at that email address, we will get those, and Dr. G will, along with myself, help you take a look at those, and we'll go ahead and answer them. If you want to give us a call and you'd like to ask questions, we'll take down your information, and then we're going to go ahead and we'll put it on this podcast, so that everybody has the opportunity to kind of figure out what it is that could help them too, and give them the answers. And that number is 951-316-9604. So again, this is our podcast today. We talked about home health versus home care. Both of them are different. and we are at the Heart of Healthcare with Dr. G. My name's Toni Kiskin. Thank you so much. We'll see you next time.
Signing out.
Thanks for tuning in to At the Heart of Healthcare with Dr. G. Help us by rating us on iTunes, and don't miss an episode by subscribing on YouTube. And be sure to click that little bell to get notified about new episodes. We can't wait to see you next time.